So let's talk a little bit about examinations, investigations, and some of the things that we can do. Of course, we have the basics, which are, your eyelid exam, lacrimal exam, orbital exam. I'm not going to go over that just because I think most of us know what a basic exam is for oculoplastics, but I do want to talk about what we do beyond basics. So the question is when you have these patients in your clinic, when do you need to do more than just a comprehensive clinical exam? And so let's start off, just talk about the eyelids. With regards to ptosis, if there's a motility deficit or anisocoria, we really want to look hard for a third nerve palsy, Horner's. Of course, acquired ptosis or an acquired motility deficit with ptosis, we're going to worry about myasthenia, so you might want to send off some myasthenia labs, do an ICE test in the clinic, look for fatigue. Whenever I see a congenital ptosis, I always think about neurofibromatosis just because I have seen a number of patients who have been treated as a congenital ptosis who have a plexiform neurofibroma that was missed. And then, of course, in those older patients or even any patient with acquired progressive ptosis where you don't suspect myasthenia, always think about things like oculopharyngeal muscular dystrophy, chronic progressive external ophthalmoplegia, and even myotonic dystrophy. With regards to lacrimal outflow obstruction, I believe firmly that when I see a patient with punctal stenosis, I need to look for an etiology to that. So if they don't have an obvious etiology, previous trauma, previous drops, previous inflammation, I do a conjunctival biopsy on these patients. So if I have a patient with punctal stenosis, I will do a punctoplasty, place stents, and then also do a conjunctival biopsy and send that for direct immunofluorescence to see if there's any evidence of mucous membrane pemphigoid or lichen planus. Now, in nasal lacrimal duct obstruction in a young person, or if it's a bilateral nasal lacrimal duct obstruction under the age of 60, I worry a little bit about some systemic associations. Of course, you want to know if they've been treated with medications such as radioactive iodine, which at high doses can cause nasal lacrimal duct obstruction. But also I look for sarcoid, I look for Wegener's, and if I don't have a good reason as to why this young person, of course I'm not talking about infants or congenital nasal lacrimal duct obstruction, I'm talking about an acquired nasal lacrimal duct obstruction somewhere between the age of 20 and 50, I'm going to look hard. I might even send them for a scan to see if anything is going on. And then, of course, if there's a lacrimal sac mass, you're going to image that. So orbital processes in general can be inflammation or neoplasm. And I think the question always is how much should we do prior to going and biopsying this patient? Again, as I said yesterday, I believe firmly in biopsying orbital inflammation. There's a lot of disagreement with regards to that. But the question is, how much should you do prior to biopsy? What should you do with regards to imaging? What labs should you check? And then we're going to talk a bit about fine needle aspiration biopsy. With regards to MRI versus CT, we had a great lecture yesterday from the radiologist looking at different imaging options and when to use those, so I'm not going to go into detail. Of course, if I need it acutely, I'm going to go with a CT. Especially after trauma, I'm going to go with a CT. And then with children, if they're non-acute, I really use MRIs just because there is this worry about exposing children to radiation. So if I can get away with an MRI in a kid, I will. The downside to that is that they have to be sedated for the MRI, so there's these different things you need to worry about in imaging kids. Orbital ultrasound, I think, is really, unfortunately, becoming a lost art. I trained at and was faculty at the University of Iowa for a long, long time, and Carlos Soenig, sort of the father of orbital ultrasound, was there, and unfortunately, I just don't think that this is something that's going to be around for a long, long time. Of course, the ultrasound for the eye will, but for the orbit itself, unfortunately, I think that we're just losing people that are good at it, and we have such great imaging options with CT or MRI. And I'd love to know if people are using orbital ultrasound a lot, because I think in the States it's something that is going by the wayside. labs for these patients with orbital processes. Of course, if you think it's thyroid eye disease and they haven't been diagnosed with a thyroid problem, send thyroid function tests. And even if they don't have a thyroid problem and you believe firmly that they may have thyroid eye disease, always check antibodies, thyroid stimulating immunoglobulin and thyroid peroxidase antibody. And then as we had discussed yesterday with regards to orbital inflammation, there's a whole set of labs that I will probably send in a patient prior to biopsy or prior to starting them on a steroid. So let's say you have a new symptomatic mass in a patient over the age of 60. To me, the vast majority of those patients are either going to be lymphoma or they're going to be a metastasis. And so there are people out there that are sort of pushing these patients just to go to PET scan, because if they have lymphoma, many of those patients may get a PET scan anyway. And if it's an acquired mass in a patient over the age of 60, there's not many other things, not many, there are a few primary orbital processes that might cause it, but I mean, I think there are more metastases as well as lymphoproliferative diseases that will cause this problem than anything else. When do we biopsy a suspected metastasis? This was looked at a little bit yesterday with Dr. Alisu Haibani as well as Dr. Sundar. And for me, it's really when it's requested by the primary oncologist, especially if the patient has widespread disease. So if the tumor is behaving differently or if they need molecular profiling and it's an easy thing to get, I'll do it. Of course, if it's a solitary, what is presumed to be a metastasis to the orbit, we're going to get a piece of that. Sometimes we'll debulk or decrease tumor burden if chemotherapy or radiation isn't working well. And then we will consider fine needle aspiration. So let's talk a little bit about fine needle aspiration. I know Dr. Sundar talked about it yesterday. I spent some time in Stockholm back in 2013, 2015. And when I was there, I was really struck by the amount of FNA that was done. Because in the States, nobody does fine needle aspiration biopsy. I shouldn't say nobody. Very, very few people do it. But in Stockholm, it really was the mainstay for diagnosing orbital tumors. And if you look at the history of fine needle aspiration in the US, there was a lot of enthusiasm for it back in the 1970s and 80s. And then a few papers came out that really knocked it down. And so in 1985, there were two papers, one that talked about the inaccuracy of fine needle aspiration, and then one that described some of the complications, three of which were death, which really stopped fine needle aspiration biopsy in the orbit in the States. However, in Europe and in India, I think a lot of people are still doing a lot of FNA, especially up in Stockholm. There are issues with regards to it, lymphoproliferative diseases. You don't have enough material often, inflammation, tough to do. But these are improved with current staining and immunocytochemistry. Meningioma could have optic nerve injury. And then there's this thought that if you do it to a pleomorphic adenoma of the lacrimal gland, benign mixed tumor, that you could get needle track seeding. But the consensus more than anything else is that you need trained individuals. You need a good cytopathologist more than anything else. And you need someone who's going to perform the biopsy. So we looked at 225 FNA samples in Stockholm between 2005 and 2013. And the questions that we looked at were what percentage of them in the orbit gave a cytological diagnosis? Does location or appearance or size make any difference? And is there a correspondence between cytological and histopathological diagnosis? And then most importantly, were there any complications? And so out of 100, out of 200, those 225 biopsies, 84% of them resulted in a diagnosis. So it's pretty good. There was really no difference with regards to where it was, although if it was relatively anterior compared to posterior, you got a better result. So that just had to do with the fact that in lesions that were anterior, you could get to them, posterior not. Size didn't matter, but 54% of patients needed no further surgical intervention after FNA. So FNA with history exam and imaging were enough. And then 97% patients went on to further surgical intervention, and the cytological and histopathological diagnoses correlated in 87%. Lymphoproliferative disease also did pretty well. 48% of patients with lymphoma, 77% could undergo treatment just based on FNA, and similar with inflammatory lesions. But importantly, very, very few complications. 5 cases with a small hematoma, 1 with subconjunctival hemorrhage, So this is a very effective procedure, and I've been trying to push it to be used in the States more. I'd be interested to hear from you all if many of you are using it. It's cost-effective, minimally invasive, and I think this is really something that we should re-embrace in ophthalmology, in orbital tumors. Thanks.